Dr. Sanjeev is a professor in the department of RML Hospital, and his area of interest is airway ultrasound in anesthesia, and his topic is guidelines 2021 standard of monitoring during anesthesia and recovery. Very important topic. Over to Dr. Sanjeev.
My presentation is on recommendation for standard of monitoring during anesthesia and recovery 2021 guidelines from the Association of Anesthetists. Human error is inevitable, and many studies have shown that adverse incidents and accidents are frequently attributed, at least in part, to error by anesthetists. Safe and efficient task performance require both technical and non-technical skills. Monitoring will not prevent all adverse incidents or accidents in the perioperative period. However, there is evidence that it reduces the risk of incident and accident by detecting the consequences of error and by giving early warning that the condition of the patient is deteriorating. This guidelines update and replace the 5th edition of the standard of monitoring. The aim of this document is to provide guidance on the minimum standard for monitoring of any patient undergoing anesthesia or sedation under the care of anesthetist. Changes from the existing guidelines are minimum standard for monitoring patient during anesthesia and in the recovery phase are included. There is also guidance on the monitoring patient undergoing sedation and during transfer. There are new sections specifically discussing capnography, sedation, and regional anesthesia. In addition, the indication for process electroencephalogram and neuromuscular monitoring has been updated. The importance of regular monitoring of blood sugar is emphasized. Anesthetists should have access to equipment for blood gas analysis, hemoglobin measurement, and flexible bronchoscopy. During anesthesia, the patient's physiological state and the adequacy of anesthesia need continuous assessment. Monitoring devices supplement clinical observation in order to achieve this. Appropriate clinical observation and examination should be done during conduct of anesthesia. A stethoscope should always be available. The continuous presence of an appropriate trained and suitably experienced anesthetist is the cornerstone of patient safety during anesthesia. The anesthetist should be with the patient at all times while the patient is anesthetized or sedated, until the patient care has been handed over to appropriate trained staff. So anesthetist should remain with the patient at all times. Training must be appropriate supervised at all times. There are few exceptions, as during regional anesthesia, anesthetists may not need to remain present during surgery under the peripheral regional anesthesia in certain specific circumstances, for example, brachial plexus block without sedation, and can proceed to perform regional anesthesia on the second patient. However, the patient being left must be conscious and communicating effectively when responsibility is handed over to anyone other than anesthetist. The anesthetist should be immediately available for the first 15 minutes following block and thereafter be contactable and able to attend within 2 minutes. But if sedation or analgesia is required, the anesthetist must return to administer it and must be present until the patient is again conscious and communicating effectively. In exceptional emergency circumstances, an anesthetist may be called on to assist or perform a life-saving procedure nearby and may briefly leave their primary patient. If another anesthetist is not available, a dedicated anesthetic assistant should remain present to monitor the patient being left. The anesthetist should return, but the anesthetist should return as soon as possible and immediately if required. Department should have an extra anesthetist whose role including attending such emergencies. During cardiopulmonary bypass, anesthetist is responsible for monitoring the patient during bypass with same standard as at all other time during anesthesia. Now coming to the anesthesia records, an accurate summary of information provided by all monitoring devices should be recorded. They recommend automatic electronic anesthesia record system, and these should be integrated into the hospital electronic health record system. And when manual anesthesia charts are used, these should be structured to allow heart rate, blood pressure, SpO2, and tidal CO2, and process EEG to be recorded at least every 5 minutes and other value at least every 15 minutes. If any additional value should be recorded, there are similar changes during this time. It may be difficult to keep record in emergency situations. So in such situation, gap in the record should be completed when the clinical situation permit by using the trend data stored in the monitoring device. Whenever handover of responsibility of patient care under anesthesia to another anesthetist is necessary, a detailed handover should be delivered to the incoming anesthetist and the handover should be recorded in the anesthesia record. And also, when taking over care of a patient, the incoming anesthetist should satisfy themselves that all appropriate monitoring is in place before accepting the handover of care. It is a responsibility of the anesthetist to check all equipment before use and be familiar with it. It is an organizational and individual responsibility that anesthetists are adequately trained in the use of all the equipment they intend to use, and they have to follow any specific equipment check recommended by the individual manufacturer. Provision, maintenance, calibration, and renewal of the equipment are the responsibility of the institution in which the anesthesia is delivered. And also, organization should involve anesthetic department in decision making regarding monitoring. Integral hypoxia mixture protection and inspired oxygen management is mandatory feature of modern anesthesia workstation. Any workstation that remain in service without hypoxia mixture protection or with the external inspired oxygen analyzer are extremely old, and such machines are to be removed from services. Now coming to the monitoring devices, whenever a patient is under anesthesia, regardless of the duration or location of the anesthesia, they consider the following to constitute a minimum monitoring of anesthesia. In all cases, pulse oximeter with plethysmograph, non-invasive BP monitoring, ECG, temperature before anesthesia and every 30 minutes until the end of the surgery, and during general anesthesia, you have to add inspired and expired oxygen and waveform capnography. And depending on the technique, if nitrous oxide is used, add inspired nitrous oxide concentration. If inhalation agent is used, add inspired and end-tidal inhalation acid drug concentration. And if mechanical ventilator is used, you have to monitor airway pressure, tidal volume, and respiratory rate. Quantitative neuromuscular monitoring has to be used throughout all phases of anesthesia whenever neuromuscular drug is used. And process EEG has to be used when administered TIVA with neuromuscular blockage. Whenever any component of anesthesia is administered by infusion, the infusion device should be checked before use and should have audible alarms. It is recommended that the intravenous cannula should be visible throughout the procedure. Anesthetists should ensure that all alarms are set to appropriate value and enable. Intraoperative hypotension is associated with adverse outcome related to both severity and duration. Non-invasive blood pressure should be measured at least every 5 minutes. The cuff pressure in the airway devices should be appropriate to prevent complication and should be monitored with a suitable manometer. Manufacturer instruction for the use of this airway should be consulted, and the pressure should not exceed recommended maximum pressure, which can be associated with increased patient morbidity. When using supraglottic airway devices where manufacturers do not specify or recommend a maximum cuff pressure, we should avoid high pressure inflation of more than 60 centimeters of water, as this is associated with reduced morbidity and improved device performance. Tracheal tube should be inflated with the minimum amount of air necessary to prevent a leak. The different cuff characteristics of the tracheal tube available in the operation theatre, the wide range of duration of surgical operations, and the lack of systemic derived evidence means there is no generalized advice on maximum cuff pressure in the tracheal tube used in anesthesia. Monitoring should continue until the patient is discharged from post-anesthesia care unit, including during transfer to the post-anesthesia care unit. During induction of anesthesia in children and uncooperative adults, it may not be feasible to attach all monitors before induction. Under these circumstances, monitor should be attached as soon as possible, and reason for the delay has to be recorded. During tracheal intubation, wavefront capnograph is a gold standard having both high sensitivity and specificity. Uninterrupted capnograph monitoring should occur during induction of anesthesia, airway insertion, maintenance of anesthesia, during any transfer, and also during emergence from anesthesia. This includes until a tracheal tube or supraglottic devices is removed. During sedation, capnograph should be used whenever verbal contact with the patient is lost. It is also advised for the light level of sedation to aid monitoring of airway patency, respiratory rate, and temperature. Residual neuromuscular blockage is defined as a train of 4 ratio is less than 0.9. Remain an important issue with report incident ranging from 4% to 64%. Clinical tests of recovery are inadequate with sensitivity of 10 to 30% and positive predictive value of less than 50% at best. And also clinical science similarly do not exceed residual blockage. Qualitative peripheral nerve stimulator assessment is unable to guarantee adequacy of neuromuscular recovery. Therefore, quantitative neuromuscular blockade is essential and should be used when administered neuromuscular blockade drugs. Every operation theater or location where neuromuscular drugs are used should be equipped with a quantitative neuromuscular monitoring devices. The monitor should be applied along with other essential monitoring, activate after induction of general anesthesia, but before neuromuscular blockade, and has to be used throughout all phases of anesthesia. Adequacy of recovery should be demonstrated and documented before patient is awakened and extubated. Whenever general anesthesia is maintained by means of inhaled anesthetic drugs, measurement of the end-tidal anesthesia concentration confirms that the anesthetic drug is being delivered to the patient and can provide an appropriate indication of the drug concentration in the patient blood and brain. Maintaining ETAC is more than 0.7% age-adjusted MAC during maintenance of general anesthesia with the inhalational agent drugs appear to be an effective means of reducing the risk of accidental awareness under general anesthesia. It is recommended that the monitor should have the facility for measurement of end-tidal anesthesia concentration and age-adjusted MAC. Process electroencephalogram monitoring provide depth of the anesthesia and indication of the effect of the most commonly used general anesthetic drugs on the electrical activity of the frontal cerebral cortex. It may aid the anesthetist in adjusting the dose of anesthetic drug being given to an individual patient and reduces the incidence of adverse effects. Process EEG monitoring may reduce the risk of accidental awareness during general anesthesia, improve early recovery time, and reduces the incidence of post-operative delirium and cognitive dysfunction. Therefore, process EEG monitor should be used when DIVA is administered together with the neuromuscular blockade or when it is used alone. Monitoring should start. The process EEG monitoring should start before induction and continue at least until full recovery from the effect of neuromuscular drug has been confirmed. The standard of care and monitoring required during transfer of patients who are anesthetized or sedated is equivalent to that required in the operation theatre, and the personnel with adequate knowledge and experience should accompany the patient. This includes patients who are being transferred from the operation unit to the post-anesthesia care unit. A tested and functional oxygen supply sufficient to last the duration of transfer is essential for all patients. They recommend a target perioperative capillary blood glucose range of 6 to 10 nanomole per liter. Check before induction of anesthesia and monitor regularly during the procedure. The lower limit of 6 millimoles per liter is to act as a buffer to ensure action has to be taken to prevent hypoglycemia in a surgical patient, especially if the patient is on glucose lowering medication. Anesthetist should have the immediate access to capillary blood glucose and capillary blood ketones monitoring equipment. Patient with diabetic mellitus controlled by medication should have their blood glucose monitoring interoperably at least hourly. Whenever anesthetists are required to administer general or regional anesthesia and or sedation in a location outside the operation theatre, the same monitoring is essential Same essential standard of monitoring is required as in OT. MRI unit presents unique challenge for anesthetists. The minimum standard of monitoring in both the MRI induction area and scanner should, however, be the same as that provided within the operation theatre. MRI safe or conditional equipment may be different to that used elsewhere in the hospital, and anesthetists should receive specific training with this equipment before use. In addition, MRI safe anesthesia machine and monitors are often more basic, so this area should be considered as high risk. Therefore, the MRI unit setup should allow remote monitoring in control unit while scanning is taking place. Now, during sedation, the same standard of monitoring should be applied for patients receiving sedation as for general anesthesia. Capnograph should be used in patients whenever there is loss or likelihood of loss of normal response to verbal contact. The provider of the sedation should remain present during the episode of care and regardless of the depth of anesthesia. Whenever regional anesthesia is performed, the same minimum standard of monitoring should be applied as for general anesthesia. Capnography should be used in patients whenever there is loss or likelihood of loss of normal response to verbal contact. When regional block is given for analgesia purpose and the patient will not remain in an operation theatre or critical care environment, a suitable period of 30 minutes of minimum monitoring should be maintained to monitor adverse effect of the bolus of local anesthetic agent. So in the end, the recommendations are: first recommendation is adequate supervision required that anesthetic should be present throughout the conduct of anesthesia or administration of procedural sedation. When general anesthesia is used, we have to use minimum monitoring of ECG, SpO2, non-invasive BP monitoring, capnography, and also aid suggesting minimal ambient concentration monitoring if inhalation agent is used. And during regional anesthesia, regional anesthesia required minimum monitoring of ECG, NI, BP, SpO2, and this should begin before the procedure and should be continued at least 30 minutes after the block completion. Procedural sedation required minimum monitoring of ECG, SpO2, non-invasive BP monitoring. Capnography should be used during procedural sedation whenever there is a loss of contact to verbal communication. Transfer required minimum monitoring of ECG, SpO2, NI, BP, and if airway devices are in place, use capnography. Quantitative neuromuscular blockade is used when neuromuscular drugs are administered throughout all phases of anesthesia. It should begin before initiation of neuromuscular blockade and continue till recovery from the anesthesia. Process EEG should be used whenever TIVA is administered along with TIVA is administered. It should start before induction and continue at least until full recovery from the effect of neuromuscular blockage has been confirmed. Capillary blood glucose and ketone monitoring should be immediately accessible. Most important, also important is the alarm limit for all the equipment should be set to the patient's specific value before use. Audible alarm should be enabled during anesthesia. And anesthetic record should be made with an accurate summary of the information provided by all monitoring devices. They recommend automatic electronic anesthesia record system. Additional equipment and monitoring analysis should have access to includes blood gas analysis, hemoglobin measurement, flexible bronchoscopy for confirmation of airway. Thank you.